Hello and welcome to the type 3 hypersensitivity lecture. Now let's begin with its definition. Type 3 hypersensitivity is induced by antigen antibody complexes that produces tissue damage as a result of their capacity to activate the complement system. Antigen antibody complexes may be circulating or in situ, exogenous or endogenous, and systemic. First of all, circulating or in situ, that is circulated within the blood. Exogenous may be infectious agents and drugs. Endogenous complex are nuclear antigens in SLE, immunoglobulins in reactive arthritis, streptococcal cell wall antigens in acute post-streptococcal glomerulonephritis, and HBs antigen in polyarteritis nodosa. Example of systemic complex is acute serum sickness, which is prototype of a systemic immune complex disease, or local adverse reaction, local immune complex disease. Now let's discuss about pathogenesis of type 3 hypersensitivity. First of all, formation of antigen antibody complexes, this is the first phase. Then deposition of immune complexes in various tissues, that is second phase. Then initiation of an inflammatory reaction in dispersed sites. Initiation of an inflammatory reaction in dispersed sites throughout the body. This is the third phase. Factors influencing deposition of immune complex in various tissues. Size of immune complexes. Large complexes have antibody excess, complex with many free immunoglobulin G Fc regions, and are readily removed by the mononuclear phagocytic system. Small and medium-sized complexes have antigen excess, are cleared less effectively, and are the most pathogenic complexes. These small and medium-sized are more pathogenic. Functional status of mononuclear phagocytic system MPS. Intrinsic dysfunction or overload of MPS increases the probability of persistence of immune complex in circulation and tissue deposition. Charge of immune complex. The three-dimensional structure of immune complex. Valency of the antigen, affinity of an antigen to tissue components, and avidity of antibody. Hemodynamic factors. Now, favored sites of deposition of immune complex. Renal glomeruli, joints, skin, heart, serosa, and small blood vessels. Now the morphology. Necrotizing vasculitis, fibrinoid necrosis and neutrophils in the vessel wall. Swelling and proliferation of endothelial and mesangial cells. Endothelial cells and mesangial cells get swollen and proliferated. Neutrophilic and monocytic infiltration into glomeruli. Hypercellular glomeruli. The morphology seen in immunofluorescence is granular lumpy deposits of immunoglobulins and complement. In electron microscopy, the morphology is seen as electron dense deposits. Now, mechanism of immune complex mediated tissue injury. First of all, antigen and antibody makes the complex. Which activates the complement. It also aggregates platelets and activates Hedgeman factors. Now, complement activation causes release of chemotactic factors, after then neutrophil aggregation and monocyte recruitment, then phagocytosis, then release of lysosomal enzymes and C5 to 9 complexes, then necrosis, then finally fever, arthralgias, lymphadenopathy, urticaria and proteinuria. Now, the complement activation causes anaphylatoxin generation, which causes release of vasoactive amines, then vasodilatation and edema. The Hedgeman factors causes activation of kinins, which causes vasodilatation and edema, as same as the sequence of complement activation. Then microthrombi formation occurs, also causes platelet aggregation and activation of Hedgeman factors. It also causes release of lysosomal enzymes and C5 to 9 complexes and further necrosis, fever, arthralgias, lymphadenopathy, urticaria and proteinuria.